Hello friends, this is Dr. Sourabh Patwardhan from Nandadeep Eye Hospital, Sangli, Maharashtra, India. And in this video, we'll be speaking about some of the causes of post-operative inflammation. Now, most of the times when we do uneventful phaco, we want to have this great outcome where not only patient has great vision, but patient is very comfortable, has no inflammation, no redness, no congestion, and patient is very happy. But unfortunately, in some of the cases, we find unwanted inflammation. So patient may have some discomfort, redness, recurrent irritation, and which is bothering us. So in this video, I'll be discussing few of the causes for postoperative inflammation, particularly the non-infectious causes and non-ocular surface issues, and which can be prevented intraoperatively. The first and most important cause is the retained OVD. Dispersive agents are always more difficult to remove completely. Wash thoroughly under the aisle, which is very important, and don't forget the angles. Cohesive OVD is easier to aspirate, so you can use it in few cases. Hydroimplantation is another option, but definitely I would not recommend it for beginners, but with experience they can use this option. If you have used heavy dispersive OVD like viscoat or Hylucoat, it is important to wash it right from underneath the endothelium in the angles and also behind the IOL from the back. In the beginning, you may be little apprehensive to go behind the IOL, but let me tell you, it is not at all difficult. So just go behind, keep your aspiration port always anteriorly and just go with the highest vacuum, and you will be able to aspirate all the viscoelastic from the bag, and it avoids capsular distension, myopia, recurrent inflammation, and raised IOP in the post-operative period, and you will find you will have much more comfortable patients. Also, in cases of plate haptic IOLs where it might be difficult to go behind the IOL, you can use hyaluronate, which is a cohesive agent. So aspirating it out is very easy because it comes out in bulk. So I think for these kind of IOLs, I usually try to use a cohesive OVD to implant the IOL. Now this is the hydroimplantation. Once you are experienced, you can use this method, particularly in IOLs which can be injected by push method, but not for screw type of injector. It cannot be used. Also, it cannot be used for 3-piece IOLs, but it's a nice technique to have in your armamentarium. The second most important cause is a retained nucleus piece. This is annoying. Commoner with small pupil, hard cataract, because there are many fine pieces which are made during and may get stuck in the OVD under the iris. And it's always important in such cases that you should have a suspicion in mind that there might be something under the iris. Look for any area of the iris where there is kind of a bump. Also, flush under the iris before you finish off the surgery. So if any piece is stuck there, it comes out. And in post-operative period, if you find such piece in the anterior chamber, just wash it immediately. The third important cause is iris trauma. Again, it is very common with small pupil, floppy iris, more common with beginners because they don't have control over the vacuum. Higher inflammation chances are there with uveitic cases if you catch hold of the iris. So whenever in such cases where you might be catching the iris frequently, or you have traumatized the iris, what I do in such cases is that I step up the steroids. So it can be either systemic steroids or even the topical steroids, and give them for a longer post-operative period to take care of the inflammation. It's very important because once iris is touched, there is always higher chance of inflammation post-operatively. Improper IOL placement. Now, every IOL has to be properly checked before closing the surgery. For sulcus placement, 3-piece IOL and large size PMM IOL is recommended. Make sure both the haptics are either in the bag or in the sulcus as per the plan. In small pupil, use retractors or Kuglen hook to inspect the placement of the IOL before closing the surgery. And single piece hydrophobic IOL in sulcus, which is unsupported, is a bad idea. It gives rise to a lot of inflammation in the anterior chamber and iris trauma. So make sure this IOL is right in the bag. Many times when you are finishing the surgery, you just feel that the IOL is in the bag and you finish the surgery, and next day you find that one of the haptics in the sulcus, or it might just pop up into anterior chamber. So don't hurry and just inspect the IOL well. If one haptic lies in the bag and one is in the sulcus, sometimes the haptic in the sulcus will start irritating the iris, and then you may have to replace the IOL or push the other haptic in the bag. So it's always important to make sure that the IOL is right in the position before you close the surgery, particularly in small pupil cases, because many times you blindly push the IOL in the bag. Like here I am inspecting that the haptics are right in the sulcus where I wanted to place them before I remove the pupil expansion ring. You can use either Kuglen hook, you can use iris retractors to check that haptics are right in proper place. Vitreous wick is another issue. So whenever there is a vitreous prolapse because of rent or dialysis, at the end of anterior vitrectomy, inject pilocarpine, constrict the pupil, sweep under the incisions before finishing the case, and examine the pupil margins very carefully, because many times you feel that you have done the vitrectomy well, but if you watch the pupil margin very carefully, you will find there is a fine tag which is going into the incision, and this gives rise to vitreous wick, and it causes inflammation in the postoperative period. Patients many times have more sensitivity to bright light, so it is best to just cut it off using the antivitrectomy probe right before you close the surgery, and this single step avoids future issues with the patient. Sometimes patient may not have any symptoms, but most patients have discomfort as the time goes on, and when patient goes in bright light, usually they have discomfort. So to remove this, if it is a small fiber like this, you can just constrict the pupil, use YAG laser, and without any offset you just fire on this tiny vitreous fiber which is there, and you will be able to cut it using laser. As you cut the laser, the pupil starts rounding up slowly, and over a period of time it becomes more and more round, and this takes care of most of the issues. But instead of strand, if it is a big vitreous membrane which is prolapse, you have to do antivitrectomy rather than trying this YAG laser. So for more such videos, do subscribe to my YouTube channel. Also visit our website phacotraining.org.in. Thank you.